Good to see you all. Today's session is about an introduction to DCAQ. My name's Gareth. I'm one of the improvement advisors in the team, and I'll be delivering the session today. So just before we get started, a little bit of housekeeping. As the cameras and the mics have been disabled, as this will be a resource we use on our website, the chat box is working and should be visible to you guys. So I'll use that for any questions and answer them anonymously at the end should any arise. And just a wee reminder that when the session's done, to remember to click leave to leave the meeting. So the QI skills sessions are part of our Primary Care Improvement Collaborative and form part of the learning session. And they've been developed to kind of support the collaborative to understand how QI tools are used in that primary care setting, particularly in relation to our pharmacotherapy teams, CTEC, and also access. Reference there is the PCAP Primary Care Access Program that we worked on previously. And the purpose of the QI skills session is to share some practical applications and some learning. So first of all, just a little poll. We run these every session. It's just to see how this has been pitched. There should be a wee poll popping up on your screen. If you just rate your knowledge of DCAQ, demand, capacity, activity, and Q on that poll, it will give us an idea of what the knowledge level is. We'll also repeat the poll at the end of the session just to see if anybody's been able to pick anything up of it and where we should be pitching future possible follow-up sessions for this as well. So I'll just have a wee look, and yep, it looks like aware of what it is, but beyond that, not much. So what are the aims for this session? So we're going to introduce the concept of DCAQ. We're going to understand what we mean by system flow, and then, I think crucially for this, discuss where you might be able to use this approach when it comes to your own work and your own practice in primary care. So some examples of where this approach has been applied with successful outcomes. As I mentioned previously, some of these examples come from our previous primary care access program. You can see there are a couple of them focusing on increase in face-to-face routine appointments, looking at that balance and releasing clinical capacity. Increase in activity when it comes to HRT prescriptions and more specifically review times for them. And also a reduction in acute prescriptions, so looking to affect that overall burden of the prescribing workload. So those are just some of the stories that we have there. So first of all, and probably quite helpful, what is DCAQ? Demand, capacity, activity, and Q. It basically is a system about using data to help us understand flow through a system by breaking it down into 4 separate components, the aforementioned demand, capacity, activity, and Q. By understanding those components, it allows us to look at where we might want to target our improvements specifically in the system at a process. And when I talk about understanding flow, we have to talk about what we mean by flow. So we've got a little thing there about the movement of patients' information or equipment between departments, staff groups, or organizations as part of their pathways of care. DCAQ and flow, they're often spoken of together, but they are different. Flow is almost like your activity over time. DCAQ is an approach where we use the data to help measure effective flow. When flow isn't as good as you want it to be, using DCAQ then helps you understand whereabouts you might be able to target improvements to that overall flow. So that's flow. Helps us to reduce harm, reduce mortality. Crucially, I think in primary care, the pressure on the staff and the system and the improved care experience might be what we're looking at when it comes to some of those improvements, particularly when we look at some of the scenarios and examples that we'll talk about just a little bit later on. What do we mean by DCAQ? So here we've got it broken down. So our demand is the work that is being requested or coming into the system. Specifically within primary care, it's useful to kind of think of this as the need. Secondary care generally has what you might call gatekeepers for entry into the system, be it referrals such as referrals from primary care, and you don't always have that in primary care. It's possible in primary care even just now, I could pick up the phone and call my practice, thus creating demand in the form of an additional call. You can sometimes, for a very rough and ready look at demand, just look on a day at the incoming calls to the practice. All of that is demand that is being placed on the system, on the practice. Maybe you're not in a practice, maybe on the pharmacotherapy team, the CTAC team. Demand actually includes the work that's actually being done. You'll see it there as mentioned as the activity, and the work that needs to be done but isn't yet, that kind of hidden demand, or as we see here at the bottom right, the Q, the unmet need that's not been done. The capacity is what we could be doing. So it refers to, what is how much work that could be theoretically done within our system. It's dependent on a few things. We've got a few mentioned there: staffing, equipment, room availability when it comes to community settings, geography, the existing caseload. Where it's really important when it comes to using DCAQ is to look at your actual capacity rather than your theoretical capacity. Your theoretical capacity can often be calculated, say looking at rotas, looking at who's on duty, looking at who's scheduled. But there can always be a mismatch between the theoretical capacity and the actual capacity due to lots of factors that haven't been taken into account, some of which might be, say, travel time around home visits, management, meetings, huddles, annual leave, sickness, and the effects of maybe doing, say, training events on the available capacity. Then there's the activity. The activity is probably the one that's the easiest to actually collect data on because it's the actual work that's being done. It's important to note as well, there's often a perception that the activity is the demand or the capacity. It often isn't. It can be, but it's not. Activity is basically why these services exist. It's also important to note that some activity can create demand further down the line. For example, taking bloods will create a test result that then needs to be communicated to the patient further down the line. Q is the work that has not yet been done or that we're unable to do. So it's closely linked to demand in that it's our unmet demand. Now, this is slightly easier to measure when it comes to secondary care because you just have to turn on the news and you'll hear about waiting lists are going up or down or round and round, and that is fairly easy to measure. In primary care, sometimes it's easier to understand this as the kind of the overspill or the unmet need. And in primary care, that Q, that unmet need, it may return the next day. You may not have been able to get through for appointment one day, call back the next day, but it also might go somewhere else in the system. You might take it to the pharmacy. It might be a call to NHS 24. You may look at out of hours, minor ailments, A&E in taking that unmet need somewhere there. It's also important when you think about that unmet need about people who couldn't access the service at all. For example, they couldn't get through on the phone, so it's not been locked. So unmet need could be in a few different places in the service. It also might be invisible to us or hard to determine, which of course, if you can't see it, it's hard to determine. It makes it a little bit harder to measure. So looking at an overview, in a kind of perfect world, all of these would be the same amount. But we all know that that's not how things work in reality, and there's a more kind of true to life reflection. So to sum up in a very kind of bare bones way, demand is all the requests entering the system. Capacity is what we have to deal with the demand: staffing, premises, geography. Activity is the amount of work that we're doing within the capacity that we have. And the Q, the unmet demand, as I said, it might be picked up elsewhere. The Q is also the area that might have the most impact on the patient experience and outcomes and how vocal the patients are about the services that they're accessing. So, why should you use DCAQ? Delays within systems occur when the flow into the system is greater than the flow out of the system. DCAQ allows you to identify the reasons for the delays and the part of the system that's causing the backlog. This can then help us to optimize the flow through the system, creating a better patient and staff experience of the process. So I mentioned there about highlighting the reasons for the delays and where the challenges are, and highlighting the bottlenecks and the constraints. And just a quick definition to a bottleneck, it's the part of the system where flow is obstructed, thus causing waits and delays. But there's usually a kind of root cause of the bottleneck, and that's the constraint that we need to look at within that bottleneck. So how should you use DCAQ? You want to look at the demand part of it. And again, as I mentioned, DCAQ is that kind of analytical data-driven approach. Collecting data to know sample if general practice teams are delivering interventions on the CTAC specification. So the demand for CTAC might not be met by the CTAC service, but it might not be known to the CTAC service as patients may not be routed to them. We've mentioned here about using public health data regarding long-term conditions to look at prevalence within patient. Comparing the activity in the practice with the number of patients with conditions. Are you seeing them all? And those long-term conditions create demand in the form of monitoring requirements, prescriptions. You might need annual reviews when it looks to reauthorizing someone's repeat prescriptions. We've also mentioned data about identifying multiple intervention single patient contacts. Multi-intervention could be all clinicians. Appointment might be made, but in actual fact, the patient might have a number of complex clinical needs. The appointment may take longer than allocated, thus causing a little bit of a bottleneck later on in the system. Or the clinician involved might not be the best clinician to respond to all of the need. And then there's an impact on communication or documentation. And then thinking about, can particular patients with complex needs be supported differently? Longer appointments automatically allocated? Do we look to collect a different amount of information at the time the appointment's made, thus allowing our clinician, whoever they may be, to be better prepared for the patient contact? Capacity. We look at our workforce, our whole-time equivalent, our vacancies, our accommodation, our premises. Accommodation, there's demand for clinical rooms, obviously. So where can admin be done? Where's the remote working opportunities? The appointment length. Other considerations such as occurrences variation, the need for, say, interpreters. What's the impact on the time needed? How often is an interpreter needed? Has it been clearly communicated that an interpreter is needed? Training needs. Who can deliver what care? And you have the team working to the kind of top of their competency, which will furthermore then have an impact on job satisfaction, and recruitment retention is a hugely important thing when it comes to our primary care services, and also just staff well-being in general. Mention there exploring opportunities for hub working. Hub working kind of allows those non-clinical activities to be carried out in a non-clinical setting, thus freeing up our aforementioned clinical space that might be in high demand. All of these capacity issues will have an influence on the number of appointments that can be offered and thus the amount of activity that can be done. So, activity. A key example would be week of care audits carried out, understanding clinical workload. As I mentioned way back in the other slides, the activity is often the easiest part to measure because we're looking at the actual activity that's being done, data on the number of patients seen, prescriptions. There's the number of IDLs processed. There may be variation who is processing the IDLs. Some of it may be done, as I mentioned, remotely at a hub, and some of it may be done in practice by the clinicians. All of it is activity, but it can be activity done by different members of the team. And then lastly, our queue. And I mentioned previously, it can be difficult sometimes where that unmet need could be seen as invisible or hard to see. There will be some that you can collect. The first one there, data on the number of patients being asked to call back as no appointments are available. Understanding patients waiting for polypharmacy reviews, waiting on results, knowing how long they need to wait for a routine appointment. All of that can give us information on the queue. So when you put the 4 pieces of the puzzle together, you get a nice overall view that really helps you understand the system and where those possible bottlenecks might be occurring. So here's a simple scenario to give an example of DCAQ. Scenario being that a staff member doesn't specify what grade, what level, what speciality, unavailable at short notice. Appointments need to be cancelled and patients reappointed. So the demand, there's now additional appointments required. The capacity, the clinical space planned for use, and fewer appointments available overall. The activity, there's workload, additional workload for the admin team when it comes to reappointing those well, first of all, the cancellations, the notifications, and then the reappointment. And then the queue will be the patients waiting for the rescheduled appointment. It may not be possible to fulfill all that additional demand at once. It may need to be scheduled. It may form queue within the system. Another scenario here. Patient requires blood tests, attends CTAC. So demand is the CTAC service appointment and the GP time to review the results. Now, results may or may not be reviewed by GPs depending on how your service is designed. This is just an example scenario that we can talk about. We see here, CTAC service have plan appointments. Does the GP have time for the results review? Activity here, the CTAC timer and the GP time, and the queue is the patient that needs to wait for the results to be communicated. These, and even though we're looking at it in terms of demand, capacity, activity, and queue as 4 separate things, they all influence each other. So for just an example on how they all influence each other, the number of acute prescriptions processed is activity, which is carried out by the available staff, which is capacity. That resource may well be split between GPs, pharmacists, other prescribers. This capacity resource is finite, so work is prioritized, which impacts on the ability to process other work, such as in the case of the pharmacists, those patients who need polypharmacy reviews, which is then demand for polypharmacy reviews, and therefore creating a queue for polypharmacy reviews because of that other activity that's being done. So whilst you could break it down to different things, do think about how each of them will affect the other moving forward, and especially when there's a variation in the system. So that's a brief overview of DCAQ. I'm going to have a quick look into the chat box to see if there's any questions. Do feel free to post any that you like. None just now. Of course, if anybody wants to post, we can always get back to you offline. As I say, this is being recorded, so I'm afraid I can't ask you to come on camera or off mic. What we're going to do now, though, we're going to launch the poll again, just to see if we've had any impact in the session on that understanding. So please rate your knowledge of DCAQ. Hopefully that poll will be launched just now. You can have a look at it. And I'll give you a few wee seconds just to answer that before I tie everything up. Great, thanks very much. So thank you all for attending. If you have any feedback on the session, please do feel free to pop it in the comments. These sessions are for the collaborative, they're for everybody, and we really want to make sure we pitch them at the right level for folk. Any follow-up questions that you might go away, have a cup of tea and think, oh, I wish I'd asked that, feel free, do get in touch. This recording will be available soon, and any other tools and resources that we have will oh, I've got a couple of questions popping up, sorry. So previous sessions are available on our website. Hopefully Melissa will be able to share the link to those. As I mentioned, this is session 5, and we have them planned monthly ongoing. I think the next one is on driver diagrams and aim statements. So a very useful one for any improvement projects. And yeah, with that being said, thanks very much for attending. Hopefully we'll see another session soon, and do get in touch with us if there's any support we can give with your ongoing improvement work. Thanks very much. Goodbye.